and we will be publishing the recording on the internet. The talk will be available in the next couple of days, so you will receive an email letting you know when the recording is available. There will be an opportunity for you to ask questions at the end of tonight's session, so please put any questions into the chat and we will get to as many of those as we can at the end of tonight's talk. We're aiming to wrap up at around 6:30 p.m. tonight. So I think that is everything from me. So without any further ado, I will pass over to our speaker for tonight, Dr. Dimitris Papamargaritis, who's going to talk to us about treatment of obesity. Dimitris, over to you.
Thank you very much, Esther. So hello to everyone. From me, I'm one of the NIHR clinical lecturers in diabetes and endocrinology at the University of Leicester, and the talk today will be about obesity treatment, what is the present treatments and what would be the future in terms of treatment. So this is my conflict of interest. And talking about obesity prevalence in England, the prevalence has been increased by 15% in 1993 to 28% in 2019, so almost double the prevalence of obesity. And when we're talking about obesity here, we're talking about BMI more than 30, body mass index more than 30. And from this 28%, approximately 3%, there are people with severe obesity, severe and complex obesity. And we see that women are having more severe obesity compared to men. 4.5% of women in England, they have a body mass index more than 40, and 2% of the men having a body mass index more than 40. So body weight is highly influenced by genetics. Approximately 40 to 70% of our weight is influenced by genetics. But the reason that we have this increase, almost doubling obesity rates over the last years, is mainly because of the environment. So there are people that they had the genetic predisposition for obesity, but being in a restrictive environment like 100 years ago, you will not develop a high BMI, high weight. But being in an environment like today's environment with ultra-processed, high-calorie foods around, available at any time, this shifts the curve to the right. And why we care about obesity is not because of an aesthetic problem, it's mainly because of the complications of obesity. So through multiple different mechanisms, obesity can lead to hypertension, can lead to high cholesterol, diabetes, cardiovascular problems, even some time of hormone-related cancers like breast and endometrial cancer, sleep apnea, osteoarthritis, and all this leads to stigma related with obesity and multiple other comorbidities. So BMI on its own is not a very good indicator of mortality in the long term. But if, as we see in the first graph, we classify patients with obesity based on the complications that they have developed from obesity, and here this is a scoring system called Edmonton Obesity Staging System. If you don't have any complications, the mortality is very low. When if you have established complications like diabetes and hypertension with the green line, then mortality is higher. And if you have end-stage damage like heart failure, COPD, then the mortality, if you have obesity plus this comorbidity, is even higher. So people with obesity plus obesity-related complications is the ones that needs to prioritize in terms of treatment and will be benefit more. In order to get treatments for obesity, we need to understand whether obesity is a disease or it is just a condition. And there is a lot of discussion about this. If we consider obesity as a disease, what are the signs of obesity? Signs is the excessive adiposity. This is pretty obvious. We can identify signs of obesity. But what are the symptoms of obesity? What is the symptoms that the patient will tell you and you will think, okay, there is here a problem related to obesity? The symptoms is, if you listen carefully to the patients, you will listen to them saying that I feel hungry all the time, or I don't fulfill with what I'm eating. It's about hunger, and satiety. And pretty much every person with obesity will have these symptoms. And what is the main organ contributing to obesity? The main organ contributing to obesity appears to be the brain. And we know that more than 80% of the genes linked to obesity are expressed in the central nervous system. And we know also from studies back in 1970s and 1980s that the satiety center, the hunger and satiety centers are deep into the brain, into the hypothalamus area, as well as close there is also the reward centers. And this is an area which works in the subconscious element, means that you do not have control of the satiety and hunger signals that the person is having. So if we have to target an organ of the body, is the brain regarding obesity. And I can say that obesity is a disease of dysregulated appetite. And this is something that obesity is a disease has been recognized by the World Obesity Federation as obesity, a chronic, relapsing, progressive disease process. And this also has been recognized by the Royal College of Physicians in England. And going to talk about treatment, they're using the terminology chronic and relapsing disease. And this is because a lot of people were seeing they're able to lose weight, significant amount of weight, 7 or even 10 kilograms. But with lifestyle interventions, to maintain this weight is challenging and is difficult. And 5 years down the line, the majority of the weight loss for the majority of the people will be regained. And this is happening not because we don't have the willpower to maintain the weight, but because the physiology is working against you when you're going to the weight loss state, when you're losing weight. And there are two things that are happening. The one is that your appetite is increased, and this is because of the signals, the satiety hormones that they're getting lower, and the appetite and the hunger hormones that they're getting higher from the gastrointestinal tract, from the gut. But also the adipose tissue will send signals to the brain to reduce the energy expenditure, which is the calories that you burn for your basic activities during the day. So if you're losing weight, you will feel more hungry, your body will burn less calories for the daily activities, and the food will be much more rewarding. And so in order to maintain the weight loss that you have achieved, you need to do a persistent effort, a constant effort to maintain this weight loss. And this is important to understand because obesity has there is a lot of weight stigma, which is coming from the lack of understanding of the physiology of obesity, and that this is not about willpower, this is about physiology in a significant amount. So it may not be your fault that you cannot lose and maintain weight through lifestyle interventions. And if we want to think about obesity and what could be the potential treatments, we know that the most effective treatments are diets, medications, and bariatric surgery should work on the appetite, should make you feeling more full and less hungry. And to summarize all this, if we think about that the lean person needs a meal of around 1,000 calories in order to feel full, an obese person will need maybe 1,500 calories meal in order to feel full. And if we want to help them lose weight and maintain the weight, we need to reduce their appetite and make them feel full with significantly less calories. How do we manage obesity in UK? The system that we approach obesity in UK is in 4 levels. The tier 1 is the prevention really of obesity with information and advice on healthy eating and physical activity, which usually is in primary care. The tier 2 is a referral to community dietitian to help with evidence-based lifestyle interventions. The tier 3 includes referral to the specialist weight management service in each area, which can contribute pharmacotherapy, low energy diets, as well as, if required, pre-bariatric surgery care. And the last step in terms of management and of obesity is the bariatric surgery, which is the tier 4. So the treatment options, as we discussed, is lifestyle changes, diet and exercise, medications, and bariatric surgery. And the next question is, how much weight loss is beneficial? How much weight we need to lose in order to see benefit? And it depends on the complications and comorbidities of obesity that we have, but for people with established metabolic problems, it appears that we are aiming for around 15% weight loss, double-digit weight loss, in order to see significant improvement, 10 to 15% weight loss. And the treatment aims is, first of all, to achieve weight loss in order to prevent and improve obesity-related complications and improve the quality of life. And secondly, and most importantly, is the weight maintenance. And this can be very challenging, as we discussed. And here we see a classic graph of the weight loss that is happening in the first months. And then it is very variable in the weight maintenance phase. And the majority of the people will regain weight. It is approximately 80% of the weight that we will manage to lose with lifestyle interventions that we will regain over a period of 5 years. And the question that you may have is this so? Should not we try to lose weight? No, this is not the point, because as we can see here with the gray line, in people that remain obese without trying to lose weight, they have higher risk of developing diabetes, hypertension, as well as dyslipidemia, compared to the people that they lost a significant amount of weight, at least 5%, and then they regained majority of this weight. But the maximum benefit was for those that they lost weight and more than 5%, and they were able to maintain this weight. And if we look at the weight loss maintainers category, those that achieved and maintained more than 15% weight loss was the ones that they have the biggest benefit in terms of diabetes, hypertension, and dyslipidemia. What we know from bariatric surgery studies is that if you lose more than 15% weight loss and you are able to maintain this, then potentially you will live also longer. And the best study that we have so far in terms of lifestyle intervention in people with type 2 diabetes, where they tried very intensively to help them lose weight for 1 year, and then they tried to support them over the period of 10 years, make them lose significant amount of weight over the first year. And at the end of the intervention, there was a difference of around 3 kilograms between the control group and the intervention group. And despite that the intervention did not demonstrate benefit, those that were good responders to the program, to the weight loss program, and they lost more than 10% weight loss, they have benefits in terms of stroke, heart attacks. So what is the lifestyle interventions that can help us achieve significant weight loss, and what is the options that we have? And I have summarized them in this slide. With exercise alone, we can aim for approximately 2 to 3 kilograms. With diet alone, and this is a 600 reduction of 600 calories per day in what we're eating, we can achieve around 5 to 6 kilogram weight loss. With diet plus exercise, we can achieve around 8 kilograms weight loss. And with low energy diets, that is the diets that you can achieve double-digit weight loss. But as you can see, in the long term, pretty much all the interventions lead to around 5 to 8% weight loss. So we need to be realistic on our long-term expectations with this, with lifestyle interventions. And there is a lot of discussion recently about total diet replacements. There was the direct study that helped people lose weight. May have heard about this as soups and shakes and bars diet. These are very effective indeed to help you lose weight in the first 6 months. Usually you are on soup, shakes and bars under supervision of a dietitian for 3 to 4 months. But as you can see, already from the first year, there is a start for weight regain. And does it matter how quick you will lose the weight in a significant weight for aiming for 15 kilograms? In this study that they tried to lose weight very quick through partial meal replacements, through low calorie diets, or through the classic diet of 600 calorie deficit diet, and they reached the 15 kilograms weight loss over the 12 weeks or 36 weeks. The people that they were on a low calorie diet were able to easier to achieve this 15 kilograms weight loss, but in the long term the weight regain was the same. So what we can do after a low calorie diet to maintain the weight, this meta-analysis has been done in 2014. The most effective of these options was pretty much the anti-obesity medications, which help the weight maintenance. However, early medications, the medications that we have back in 2014, which was targeting appetite, were not always safe. And at this time, medications like sibutramine or rimonabad that was used were out of the market because of safety issues. And it was only Orlistat, the medication that was around. But do we have any other successful and safe models of weight loss and weight maintenance? We had bariatric surgery, and I will demonstrate to you how we use bariatric surgery to get lessons about how to create safe medications about obesity. So bariatric surgery can lead, here you can see different type of operations, but can lead on average, based on this data, on 15 to 25% weight loss. The average weight loss in this study was around 16%. And it has shown that can reduce the heart attacks and the strokes, either fatal or total amount of events. And as I showed earlier, has demonstrated also that they can reduce the risk of mortality, can increase the life expectancy. And bariatric surgery increases life expectancy by 5.1 years for people without diabetes and by 9.3 years for people with diabetes. We have new types of bariatric surgery. The bypass is the gold standard that we know for 50 years, and the band we know now for a number of years. The newest operation is the sleeve gastrectomy that you can see here in the center. And with the newest operations, you can expect with a gastric band long-term around 10% weight loss, with a sleeve gastrectomy around 20% weight loss, and with gastric bypass around 25 to 28% weight loss. And bariatric surgery improves health and functionality, but will not make you thin, will not make you achieve BMI less than 25 in the majority of the cases, and will not make you happier. But bariatric surgery is not the answer to the problem, because not everyone wants to undergo bariatric surgery. Despite that it is very safe operation, there is always risk of complications. We do not have the capacity to operate at all people eligible for surgery, despite that the UK is doing significantly less bariatric operations compared to the rest of the world. And currently only 0.1% of eligible population per year will undergo bariatric surgery. But what bariatric surgery teaches us is that the mechanism that make people lose weight was not through malabsorption or restriction. It was by reducing the appetite. The energy expenditure reduced, but also they reduced the appetite. And the mechanism that came again and again that leads to reduced appetite was the increase of gut hormones due to the changes in the gut anatomy. And these satiety gut hormones make people feel full earlier with the food and also feel less hungry. And this was pretty exciting because this GLP-1 that we found, one of the hormones, that satiety hormones that we found that it is increased, was already available as treatment for diabetes. And we used the first medication of this was called Byetta, and we have taken the medication from the saliva of the Gila monster, which is this animal that I saw in this slide. And so that's how we develop pharmacotherapy for obesity. And now the currently available treatments is the Liraglutide 3 milligrams, which is injectable treatment. This is a GLP-1 analog, one of the categories that I just mentioned to you. And this is the higher dose of Liraglutide, 1.2 to 1.8 milligrams, which is used for diabetes management. Gut hormones has multiple actions, affect both glucose as well as appetite. We have the Orlistat, which is for many years around, and it is a very safe medication, oral medication. The dose is 120 milligrams 3 times a day. And we have another one medication called bupropion naltrexone, which works both in the reward centers as well as in the appetite centers. It is an oral medication, but currently is not available in NHS settings. So who is eligible for Liraglutide 3 milligrams? This medication needs to be prescribed in a specialist weight management service in the level 3 of the 4 levels that I mentioned to you. It is for people with body mass index at least 35, and they need to have also pre-diabetes, non-diabetic hyperglycemia. They also need to have a high risk of cardiovascular disease, and yes, needs to be prescribed, as I mentioned, in weight management, specialist weight management service. This Liraglutide 3 milligrams on average leads to approximately 9% weight loss compared to 3% with lifestyle changes only. Always needs to be combined, the medication, with lifestyle changes. And around 15% of the people that will be on the medication will be achieved more than 15% weight loss, compared to 3.5% of the people on lifestyle changes on diet. And you will be able to see if this medication works for you very early. From the first 16 weeks, you will see that whether this medication is leading you to weight loss. And the recommendation is that people that they don't achieve more than 5% weight loss in the first 16 weeks, they need just to stop the medication, because the chances of achieving more than 10 or more than 15% weight loss when you have not achieved at the beginning is very low, is only 1.7% of the people with which did not achieve the 5% weight loss target were able to achieve more than 15% weight loss. And the interesting thing is that people on diet demonstrate a similar responder, non-responder picture. So people that were able to respond well to the diet in the first 16 weeks was the ones that at the end they have higher chances of achieving 10 or 15% weight loss. What about more than 1 year? We can see here in this study about Liraglutide 3 milligrams in pre-diabetes that you can maintain around 7% weight loss long-term at 3 years of using Liraglutide, and this leads to an 80% reduction at your risk, your pre-diabetes, to convert to diabetes. And what about using this Liraglutide medication after you have started and have done a diet and you have achieved 5-6 kilograms already? It was very encouraging, the results that demonstrated that those that they started on the medication at this level, they were able to achieve another 5 to 6 kilograms. So overall 10 to 11 kilograms weight loss compared to those that they have been given placebo, which were able just to maintain the weight that they have achieved through the diet. And we know from the Liraglutide dose for diabetes, which is the 1.8 milligram, that it is a safe medication, and pretty much is helping people to live longer. From diabetes studies, you can see that there is a 22% reduction in terms of death from cardiovascular causes, and 15% reduction for death for any cause which is statistically and clinically significant. So how we can combine best all these treatments, and this study that's published recently in New England Journal of Medicine is very encouraging. These people went initially to low-calorie diet to lose over the first 8 weeks 10 to 12 kilograms, and then they have been given or a dummy injection, or they underwent exercise, or they have given liraglutide, or they have been given combination of exercise and liraglutide. And for those that they have lost 12 kilograms and they have been to placebo, they regain 6.1 kilograms. Those have lost weight and they undergone exercise, they gained only 2 kilograms. Those that they have received liraglutide, they maintain the weight that they achieved. And those that they went exercise plus liraglutide, they were managed another 3 kilograms on top of the 12-13 kilograms that they have achieved. And so with this way, around 50% of the people that they started on diet and then they continued with exercise and liraglutide were able to manage at the end of the year more than 15% weight loss, compared to 30% of the people on exercise and liraglutide and 10% of the people on placebo. Another combination of treatments for people after bariatric surgery, because weight regain is common, using liraglutide, GLP-1 for diabetes dose here, we see that still, despite that after bariatric surgery, we have significant secretion of GLP-1 internally, still giving externally this medication, the GLP-1 still works and still can give you an extra 5-6 kilogram weight loss if weight regain is something that you experience. What about Orlistat? Orlistat, this is the nice recommendation how the doctor should prescribe the medication. Needs to be prescribed as part of a overall plan for managing obesity for people with BMI of 28 or more with associated risk factors, or for people with BMI of 30 or more. The therapy should be continued beyond 3 months only if a person has lost at least 5% of their initial weight since starting the drug treatment. And the decision to use the drug treatment for longer than 12 months should be made after discussion with the doctor about the potential benefits and limitations between doctor and patient. And the co-prescribing of Orlistat with other drugs for weight reduction is not recommended. So Orlistat can help you approximately to achieve an extra 3 kilograms weight loss, and you will maintain approximately 2 to 3 kilograms in the long term. This is from the Xendos trial. The main side effect of Orlistat is diarrhea. This is because the medication works by creating malabsorption of fat into the gut. So this is pretty much an alert when you have diarrhea with this medication that the meal that you had too much of fat. And you should avoid a meal like this the next time. And so that's how it reinforces behavioral changes. And regarding initiating the Orlistat, after you have lost a significant amount of weight, around 10 kilograms, we can see that still there is some benefit around 2 to 3 kilograms for weight maintenance compared to not having the medications. The last medication that I will talk regarding the available medications currently is the bupropion naltrexone. This, as I told you, works both in appetite as well as in reward centers in the brain. They have demonstrated effectiveness of approximately 8% weight loss compared to 1.4 with lifestyle changes. And this medication, unfortunately, is not available by NICE. So what is the future? What is coming? It's pretty exciting what is coming. The medication that will be available probably in NHS has already approved by MHRA. It's not available in NHS, but probably will be available over the next 2-3 months is the semaglutide 2.4 milligrams once weekly. Sun has call this the wonder jab that stops cravings and could help you lose weight and fight obesity. And this is pretty descriptive that this medication is a game changer and reduce the appetite. That's how it works. So the semaglutide 2.4 milligrams is a once weekly injection that leads to approximately 15 to 16% weight loss over a year. And the impressive thing in terms of weight loss is that the first time we have a medication that leads to double-digit weight loss, and 50% of the people that taking this medication will achieve more than 15% weight loss, and 1 in 3 people will achieve more than 20% weight loss. They will lose 1/5 of their body weight. Comparing to the liraglutide, semaglutide is approximately 3 times more effective, a difference around 10% weight change between the two medications. And as with every medication for obesity, this slide demonstrates that if you stop the medication, you will regain weight. So in this study, they gave medication for 20 weeks, and then the medication was randomly or switched to dummy medication, or they continue on the medication. And you can see at the end there was 13 kilograms difference between the two groups. The weak point of this medication was in people with type 2 diabetes. We're already using this medication for diabetes management in a low dose. 1 milligram is very effective in glucose level and can lead you to lose approximately 7 kilograms. However, at the high dose of 2.4 milligrams, we can see that yes, it's more effective. It leads to approximately 10% weight loss, but this is not as effective as the 16% weight loss that we saw earlier on for people with obesity but without diabetes. And semaglutide, also from the studies in diabetes, we know that it is a safe medication, and especially for people that it protected people from stroke. The draft recommendation for this medication, this is draft recommendation, is not yet approved, probably will approve at the end of the May, is that this medication should be used in tier 3 or tier 4 weight management service for people with BMI at least of 30 and reduced BMI threshold for people of South Asian, Chinese, Black African or Caribbean family backgrounds, but only use semaglutide for a maximum of 2 years. Now, what are the other potential future treatments? Is tirzepatide, the one that we expect to come over the next 1 to 2 years, and this is for people with type 2 diabetes, where we say that semaglutide had a little weaker effect at 2.4 milligrams. And we have here a study which has been done comparing tirzepatide 15 milligrams with semaglutide 1 milligram. This is the low dose of semaglutide, and you can see that tirzepatide can lead to around 12 kilograms weight loss, and this is 11 to 12 kilograms weight loss at the high dose. They are also doing studies in obese population without diabetes, but these are in early phases. So as treatment for obesity, we may need to wait more time for people without diabetes. Other future injectable treatments, and these concepts are coming from bariatric surgery, where they try to combine gut hormones and see what is the effect of different satiety hormones, is an amylin analog called cagrilintide, or the cangrisema, which is a combination of amylin and GLP-1 analog, and a new medication called bimagrumab, which is different way of working by stimulating muscle growth. And other upcoming treatments is oral semaglutide, another gut hormone, the PYY, and another appetite suppressant, the GDF-15. I will just very briefly speak about the cagrilintide, this medication which, as I told you, is about reducing again, increasing satiety. And in the dose of 2.4 and 4.5 milligrams, it was as effective and maybe a little more effective than Liraglutide 3 milligrams, which is the currently approved by NICE GLP-1 analog. And when we combine the semaglutide 2.4 milligrams with the new medication, the amylin analog, we can see that in 20 weeks after starting this treatment, these people achieve 17% weight loss, which was significantly more, approximately almost double compared to the weight loss achieved with semaglutide on its own, which was around 10%. And last, I will speak for bimagrumab, which is a different type of medication. It's not an appetite suppressant medication. It's a medication that does not demonstrate massive weight loss. You lose approximately 5 to 6 kilograms with this. But the good thing with this medication is that they increase the lean mass and reduce significantly the fat mass, reduce the fat mass by 7-8 kilograms and increase the lean mass by 1.7. So it's like exercise, treat the people living with obesity. Weight loss can be achieved through diet, but weight maintenance is more challenging. And physical activity, exercise, as well as medications can help in this direction. For maximum benefit, we need to aim for double-digit weight loss and maintenance. The new medications are promising that they will help us achieve these targets, especially the combinations of gut hormones, and the future is bright. However, we need to expect weight regain if we stop the medication. Bariatric surgery is currently the most effective and cost-effective treatment for weight loss and weight maintenance for people with severe and complex obesity. And currently, we do not have good indicators of who will respond to what treatment. I cannot tell if someone will respond to the one medication or the other medication. We're doing more research in this area, but we need, this is the direction that we're going about personalized medicine. So that's all from me, and thank you for your attention.
Thank you very much, Dimitris. That was a really interesting talk. You're still sharing your screen, as you asked me to remind you.
Yes, give me a second. I will stop sharing, hopefully. Give me a second.
That is
stop sharing.
Absolutely fine. We can see you now. It's gone a bit dark at your end, but we
yes,
can still
give me a second
you.
Just to open
you
the
need to move.
Yeah, I need to move. Give me a second.
Okay, no problem. If anybody does have any questions for Dimitris, do feel free to put them into the chat and we will get to as many of those as we can. Now he's back in daylight.
Yes. Sorry for this.
No problem at all. You haven't moved for long enough, have you? So we've had a couple of questions coming through. So current obesity guidelines recommend I'm not good at the words. Liraglutide, is that right?
Liraglutide, yes.
Yes, this is not my specialist subject, as you may be able to tell. 3 milligram without diabetes. Do you think this needs to change?
If the question is if I believe that people with diabetes needs to have also the liraglutide at the higher dose, depends on what is their response. There was a cost effectiveness analysis for this, that they identify the people with pre-diabetes as being the most cost effective to use the medication. We are using liraglutide up to 1.8 milligrams currently for treatment for people with diabetes, so they receive this medication in lower dose. But if someone is, I'm not sure, the difference is small in terms of weight loss between liraglutide 1.8 and liraglutide 3 is around 2 kilograms. So I'm not persuaded that will make a huge difference, especially to people with severe and complex obesity. So I believe that 1.8 is something that we can try, and we have more effective medications. Pretty much, if someone is having diabetes, by using the semaglutide 1 milligram, pretty much can achieve the same weight loss as liraglutide 3 milligrams.
And kind of related, why is the response of these agents different in people with and without diabetes?
Yeah, we don't have very good answer to this. People believe that in